So basically, I would like to introduce to you a normal heart. How does it look like? So there are 4 chambers in the heart. The 2 chambers on the upper part, which is the right, and this is the left upper chambers. And there are 2 chambers on the lower part, which is the right main chamber and the left main chamber. So atrial septal defect is the hole or the defect in between the right upper chamber and the left upper chamber. Right. So that is atrial septal defect. So what usually if the hole is small, it doesn't cause problem. But if the hole is significantly enlarged, so the blood flow from the left upper chamber to the right upper chamber, and this blood will flow into the right main pump or right lower chamber and to the pulmonary artery, meaning that to the lungs. So the lung will be flooded, and in the long run, usually when they are teenagers or in adulthood, the right main chamber will become enlarged, and if left untreated, they will become weakened. The symptoms for atrial septal defect is very uncertain, all right, and usually the detection is at the adulthood, teenagers or adulthood, or sometimes it can be accidental findings when the child is unwell, and I think they go for any visit to a general practitioner or the doctors that attending the child detected any what we call cardiac murmurs. So usually it is accidental findings. And then of course in children we have a few engagement, what we call an engagement period with the health care providers, especially when they are going for their vaccination or sometimes call it immunization. So I think that's the best time when they are engaged with the healthcare providers to have a full checkup, and if the growth is affected, so the child is not thriving, and the doctors can listen to the heart, and if there is any heart murmurs, they should refer the child to any pediatrician or any pediatric cardiologist. The congenital heart disease itself, it accounts about 8 to 10 cases in 1,000 live birth. So for example, in Malaysia, the live birth is about 500,000 per year. So we expect about 4,000 to 5,000 new cases every year. But out of this proportion, the ASD is about 8%. So this is among the second common congenital heart defect, right? The most common is ventricular septal defect, so this is the second common. And then usually 50% of this atrial septal defect require interventions. It's either transcatheter closure, so without surgery, or by open heart surgery. So usually the patient that's suitable for the transcatheter closure of atrial septal defect, depending on the weight of the child and also the size of the defect. Usually we use the cut-off point of 15 kilogram for children to be able for us to use the transcatheter and also to close the hole using the device. Of course, for the surgical closure, there is no weight limitation. And usually we put in the cannula in the vessels at the groin of the patient. Right. From that vessel, we put in what we call a catheter. So the catheter will cross from the vessel itself into the heart chambers. So through the catheters, we put in the device and the cable. This device is collapsed like this within the catheter. So then we introduce into the catheter and then into the heart chambers through the catheter. And the main disc, so the bigger disc, will be open at the left upper chamber and pull into the right upper chamber, and the disc at the right upper chamber will be open. So the septum or the wall of the heart will be sandwiched in between, and this cable later on will be detached from the device, right, by unscrew this, and then this one will be taken out and the device will be left at the septum. So this will close the hole or the defect. There's no major complication, and then it's much safer, and then usually the child can go home the next day. Alright, this is applicable to the adult as well. Transcatheter closure is quite safe. Alright, usually we put in the device, alright, for the following 6 months. Following the procedure, they have to take what we call antiplatelet therapy. So this is to prevent from the blood clots in the left chamber, which this, if there is blood clots, it can fly into the vessels that supply the body, including the brain, which causing stroke. So they have to be on that treatment for 6 months. And then, of course, usually we follow up the patient for about 5 years after the procedures. If within that 5 years, what we look into is the valve involvement. It's either the device impinge on the valve, or sometimes what we call the wall erosion, the heart wall erosion. So this will cause what we call a cardiac tamponade in the long run if the erosion is significant. There is reported cases of device erosion. And then other thing is like what we call the signal abnormality or the rhythm abnormality of the heart, and that requires long-term follow-up. Alright, required ECG to be done every single follow-up, so to be able for us to detect any cardiac arrhythmias if there is any.